Today I want to speak about the outcomes of treatment of stage 4 non-small cell lung cancer. So just to give overview about lung cancer is divided to two entities. The first one is called small cell lung cancer. It's about 15% of the cases, and the other part is non-small cell lung cancer, which is about 85% of the cases. Small cell, which I don't want to talk much about, is also divided to limited stage or extensive stage. But today I want to focus only on non-small cell lung cancer and specifically about stage 4 metastatic non-small cell lung cancer and the survival in these patients. So just before I speak about survival, I want to emphasize or discuss what median overall survival mean in clinical trials. What that median. So the median overall survival is the survival of the specific patient in the middle of the spectrum of patients. For example, if there is 101 patients in a trial, we put their survivals one after the other according, in ascending way. Like we put the survival of the patient one after the other, starting with the shorter survival going up to the longest survival. So patient number 51 is the median overall survival. There are 50 patients who lived less than this patient and 50 patients who lived more than this patient. So the median overall survival in clinical trial is that specific patient who survived in the median. It can be determined only after half of the patient died, and then they can determine the overall survival. So when we say the median overall survival, that means 50% of the patients lived more and 50% lived less. So today I want to speak about the overall survival with treatments for metastatic non-small cell lung cancer. So it's not stage 1 like in this case. It's very early stage, which can be cured by surgery, lobectomy, or stereotactic body radiation therapy. Not like this case, which is stage 3. It's a mass in the lung with involvement of the mediastinal lymph nodes, which can be cured also by combination of chemotherapy and radiation. But cases with metastatic disease to multiple organs, for example, this patient has brain metastasis, and we speak about multiple metastasis. So there are multiple trials that tested immunotherapy for metastatic non-small cell lung cancer in the first line of treatment. This study that I published with my colleagues reviewed many of the studies in this field, and we provided also the outcome in a nice figure of these studies. So let's go a little bit on the data on them, and these data provide here the median overall survival. So the median, half of the patient lived less, half of the patient lived more. So we need to be optimistic to look on the full side of the cup, which is, So for example, if we take a look on Keynote 024, which randomized patient with non-small cell lung cancer stage 4 with PD-L1 expression more than 50% to chemotherapy or to pembrolizumab only. We see pembrolizumab median overall survival was 30 months compared to 14.2 months, more than double of the survival. It was just immunotherapy, no chemotherapy. But remember, it's PD-L1 more than 50%. And if we look at Keynote 042, which randomized patients with PD-L1 1% or more to chemotherapy or pembrolizumab, you see here that the pembrolizumab did better than chemo, but still it's not like in patients with PD-L1 more than 50%. It's 16.7 months compared to 12.1 months. But look here. So these patients are with less expression of the PD-L1, but still the PD-L1 is expressed on these tumor cells. So it's very important. It's at least 1%. If we go to Keynote 189 and Keynote 407, the first one, the 189, included patients with non-squamous non-small cell lung cancer, and the Keynote 407 included patients with squamous non-small cell lung cancer. All of them included all comers. PD-L1 can be 0 or more, and randomized to chemotherapy only versus chemotherapy and pembro. Same randomization in both trials. And we see in the non-squamous, which mainly adeno and include also large cells, the overall survival was 22 months compared to 10.7 months. In the squamous, the survival was worse actually compared to the non-squamous, but still it was better with the combination of pembrolizumab and chemotherapy compared to chemotherapy alone. And these are all comers, PD-L1 0% or more. So immunotherapy in this setting with chemotherapy give better survival than chemotherapy, both in the squamous and in the non-squamous. Okay, so this is with the pembrolizumab. So other studies, the Empower 110 randomized patients with PD-L1 more than 50% to chemotherapy or atezolizumab. Overall survival with atezo was 20 months compared to 13.1 months. So it's statistically significant, but when we look at the Keynote 024, the overall survival was 30 months with the pembro only. So many physicians, prefer to give pembro than to give atezo if they have the option for that, depending on availability. Similar study with the Empower 130, patient with PD-L1 0 or more, non-squamous, randomized to atezolizumab plus chemotherapy compared to chemotherapy only. And here also, the overall survival with the combination was 18.6 months compared to 13.9 months. It's a median overall survival, we need to remember. Half of the patients live more, half of the patients live less. This is the median. But again, compare this study to this study, and the combination of pembro plus chemo in the non-squamous gave overall survival of 22 months. Compared to 10, and here 18.6 months with the atezolizumab chemotherapy compared to 13.9. So it's hard to compare different studies, but as we don't have head-to-head comparison between pembrolizumab and chemo to atezolizumab and chemo, but probably many people will try to give pembrolizumab and chemo, just because this more than doubled the overall survival, and here it's statistically significant, but it didn't double the overall survival. Other studies, the Checkmate 227 in patients with PD-L1 less than 1%, randomized patient to chemotherapy or combination of nivolumab and ipilimumab, and overall survival with the combination was 17.2 months compared to 12.2 months. So this combination is appealing to some of the patients because PD-L1 expression is low, and this is option without chemotherapy as opposed to here option with chemotherapy. But the combination of nivolumab and ipilimumab is much more toxic than each one by itself. So there's price for this combination. Checkmate 9LA also randomized patients with PD-L1 0% or more to chemotherapy or to chemotherapy, nivolumab, and ipilimumab. The three combination, and overall survival was 15.6 months compared to 10.9 months. So it's a question why you want to give so much combination, so much medication to get 15.6 months? You can give two medication and get 17.2 months. Like it's harder to give chemotherapy and pembro and get 22 months. And additional studies empower 150 patients with non-squamous non-small cell lung cancer with PD-L1 0% or higher were randomized to bevacizumab, which anti-VEGF antibody and chemotherapy compared to bevacizumab, chemotherapy, and atezolizumab. And the overall survival was 19.8 months compared to 14.9 months with the addition of the immunotherapy, the atezolizumab. The question, why to give two antibodies, bevacizumab and atezolizumab, if you can give just pembrolizumab and chemotherapy? So why to and get 22 months overall survival? So this is the additional option, but probably not many physicians will run to do it if you can give just pembrolizumab and chemotherapy. So the bottom line, immunotherapy had wonderful effect on the treatment of non-small cell lung cancer, especially in patients with high expression of PD-L1, but not just. In combination with chemotherapy, with patients with PD-L1 0 or more, chemotherapy and pembrolizumab are better than chemotherapy. So immunotherapy opened a door, a new horizon for treatment of metastatic non-small cell lung cancer with excellent effect on survival. And remember, this is just the median overall survival. Half of the patients live more than that, as we discussed in this figure. Thank you.